Thanks, Bill. Thank you very much. It's a real pleasure to be here. So I'm Paul Thompson. I'm the Chief of Cardiology at Hartford Hospital, which some of you may know is a fairly large private institution in Connecticut. So here are my conflicts of interest. If somebody's made a cholesterol-lowering drug, I have spoken for them or done research for them. I have additional conflicts of interest. I am from Connecticut, and we also play basketball. I just want to remind you that. And then the other major conflict of interest I have is that I am a huge Bill Krause fan. Now, the reason I'm a huge Bill Krause fan is basically the STRIDE studies. We have done exercise training studies over my career. We looked at how athletes how they metabolized HDL cholesterol using radioactive tracers and stuff like that. And let me tell you, that you want to have a miserable time, do an exercise training study. And Bill has done some of the best exercise training studies possible, looking at adaptations to exercise training and lipids and glucose metabolism, et cetera. So I'm a big Bill Krause fan, and also don't want to talk about his marathoning exploits, but he's done very well there as well. So you know that you can divide what people die from in the young, those generally defined as less than 40 years, and then adults, those older than that group. And it's pretty straightforward. If you look at sudden cardiac death in young athletes, you see that, at least in the United States, hypertrophic cardiomyopathy or probable hypertrophic cardiomyopathy are the big players. Coronary artery abnormalities or anomalies are a second big player, and then there's the usual list of suspects. It may actually be changing with time, because if you look at this study from France, which was in 2011, a fair number of these events are unexplained. Now, I don't know exactly what's going on, but there's a different prevalence of these deaths in the United States versus those in other countries. And this from Marjan in France shows what looks like a change in what we've thought all along. So I think we need to keep an open mind about that. Sudden cardiac death in middle-aged adults is almost always at coronary artery disease. So coronary artery disease is here in red. And this is from the general population, and then this down here is from athletes. And there's something I'd like to point out. So even though there's a fair amount of coronary artery disease, the red represents plaque rupture or plaque erosion. In other words, you found evidence of an acute coronary thrombosis. But something that I've found interesting over the years, we always thought that most of these deaths occurred from plaque rupture. Most of the exercise-related deaths occurred from plaque rupture. But there seems to be a growing number of these deaths that occur with non-acute coronary artery disease. In other words, exercise-induced ischemia. Now, I bring that up. We may not have time to talk about it, but I bring it up because we've not been big fans of exercise testing before competitive athletics in middle-aged individuals. But this may be time to reevaluate this because of the large number of people who seem to have non-acute coronary artery disease as their cause of death. So I'm off topic a little bit because what Bill asked me to talk about is these new guidelines. So what I've done is I've gone through the guidelines, read each one of them. There are 15 of them. And I've taken out what I think are kind of the biggest points for you to remember. And so what do I think is new? What do I think is new with these new guidelines? First of all, AFib ablation is considered sooner. Recommended in athletes to consider that earlier in the disease course. All patients with ICDs are not banned from competition. Now, don't take it too straightforwardly, because even though they're not banned from competition, many of them are only allowed to participate in relatively low-intensity sports. Genotype alone is not an exclusion. That differs from the European guidelines, but simply having the genotype for certain diseases is not an exclusion. I'll talk about the exceptions. Sickle cell trait is addressed. Some of you are aware that there's this high rate of rhabdomyolysis in sickle cell trait carriers, both participating in sports at altitude and also in dehydration, hot conditions. So sickle cell trait is addressed partly because the NCAA has come out with a screening recommendation. Emergency procedures are highlighted. I can't support Mark's push on the AED more than possible. Really, the ability to resuscitate these athletes is probably one of the best things that we can do. There's more on adult congenital patients. Now, it's an incredibly long section on adult congenital, but it's important that it's in there because these are a growing number of our patients. What else is new? There are fewer absolute mandates. There are fewer times when you're told kind of absolutely this athlete cannot participate. Now remember, guidelines are extremely conservative, and they have to be conservative because they're going to be followed by a lot of people who don't have the expertise that you folks at Duke, for example, would have. There's more placed on clinical judgment. Again, I think an important change. There's more shared decision-making with the patient. Early on, I've always written the coronary artery sections for these guidelines. Early on, there was this thing about, nope, the athlete does not have a choice in this. You have to tell the athlete what to do. But these guidelines, I think, have made a big advance in that there's more shared clinical decision-making. There's also an emphasis on other ways to reduce risk. Rather than just restriction, can you do something else with these athletes that will reduce their risk so that they can participate? Okay, so let's look at a couple of these chapters. So Task Force 1 was the classification of sports, dynamic, static, and impact. And I think there are a couple things that were important. One is a big emphasis on considering the demands of training and environment. And the point about that is that when you're evaluating these athletes with exercise testing, or you're evaluating symptoms with exercise testing, to try to get the testing to mimic their training and competition environment as closely as possible. I also think it's an advance that Valsalva was recognized to increase transmural arterial pressure outside the chest, but doesn't affect LV afterload because of the balance between intracardiac and intrathoracic pressures. You know, when you Valsalva, there's been a lot of move to restrict certain athletic activities. But when you Valsalva, some of that rise in blood pressure is simply the intrathoracic increase in pressure. So for example, the pressure across the aorta in the chest is probably not as great as we thought previously. And there's a lot of emphasis on hemorrhagic risk, primarily intracranial with anticoagulants. That was not emphasized in the past. I mean, the risk of bleeding was emphasized, but I think an important thing in these guidelines is the thing that we're really worried about is not necessarily a thigh hematoma, although if that calcifies, that can be a terrible thing for an athlete. We're more concerned about the cerebral trauma. So the second task force was about pre-participation screening for cardiovascular disease in competitive athletes. And as Mark pointed out, this is an area of great controversy. So let me discuss a couple things about it. First of all, Italy, Israel, US have screening programs, but they differ. Interesting to read the Denmark literature, because the Denmark literature says screening is unjustified. It's just unjustified. There are not enough deaths for the amount of effort to do the screening. So they, as a national health service, have just said, we're not going to do it. It doesn't make any sense. Very interesting reading. The AHA has this 14-point screening tool that nobody says is perfect, but it's the tool that has been recommended for use in the United States. It does not include mandatory ECG screening, as mentioned. So the argument about this, whether you should do ECG screening and how extensive the ECG screening comes from a lot of areas of debate. But one of the biggest areas of debate is how big is the problem? How big is the problem you're going to address? So here is from the group that's the strongest advocates of screening. John Dresner, who is, as Mark pointed out, is a family physician and the physician for the Seattle Seahawks, and Kim Harmon, both at the University of Washington in Seattle. Very enthusiastic about screening. And what they point out is that if you look at cardiovascular-related deaths in NCAA 1 athletes, there have been 45 deaths, and most of them occurred during athletics. Gave you an overall sudden death rate of 1 in 43,000, one of the highest numbers out there for sudden death. And what was really scary is that among NCAA basketball players, the death rate was 1 in 3,100. That means if you stay for 4 years in college, of course, what NCAA 1 basketball player at Kentucky stays for 4 years, right? But if you stay for 4 years in college, you have a death rate of about 1 in 800. Remarkable numbers, remarkable numbers. But if you look at it over in a different way, that death rate over 5 years in NCAA 1A athletes was only 5. So that basically gives you what? 9 deaths a year in the NCAA 1 program. So it depends on your viewpoint. It's either a lot of deaths or it's not a lot of deaths for the amount of screening you have to do. It all comes from Dominic Corrado's study on the trends in cardiovascular death in young competitive athletes. Now, I reviewed this article for JAMA, and I thought it ought to be accepted. I didn't think it was a perfect article, but I thought it was really stimulating for the discussion. And basically what Dominic showed is that over the time of their screening program, and it was not just an ECG screening program, they started a screening program that was an examination and history and all that sort of stuff, but over the time of the screening program, you can see this remarkable reduction in the incidence of death among these Italian athletes in the Veneto region of Italy. The death rate for unscreened non-athletes stayed basically the same. So their point was this screening, and they really emphasized the ECG part of the screening, really saved a lot of lives. Ben Levine and myself wrote the editorial that went along with that about protecting athletes from sudden death. And our attitude was actually on the other side. Our attitude was, sure, you showed this sort of cross-sectional, you saw this longitudinal cross-sectional comparison, but was it really the screening that worked? Barry Marin, myself, and others compared the US experience and the Italian experience using Minnesota, what happened in Minnesota. So here's Minnesota, and here's the Veneto region of Italy. They're about the same size. And if you look at what happened with deaths in Minnesota athletes, here are the deaths in Minnesota athletes from the late 80s up to almost the present. And you can see that without the sort of formal screening program that exists in Veneto, the region of Italy, that the death rates are almost the same. And you still have this remarkable reduction. The Israeli group has also started mandatory ECG screening. And they started mandatory ECG screening because there were a lot of deaths. They had a peak of deaths among Israeli athletes. So they enacted a law in 1997 mandating ECG screening. And what Sammy Viskin and his colleagues did is they looked at the death rate for the 10 years before and the 10 years after this mandatory screening program. So here it is. Here's the Israeli experience. So here's their yellow death rate. And this is what happened just before the Israeli sport law. And then there was this reduction to some extent. So the whole question is, are these laws prompted by a spike in activity? And are you really seeing, with a reduction, and like the reduction in the Italian experience, are you seeing a regression to the mean? You started this because there was a big peak, and it disappeared. So did a spontaneous blip in death rates prompt the Italian law? And did regression to the mean prove the effectiveness of screening? And quite frankly, we'll never know, because we don't have data before that law was enacted. Now, I'm a little skeptical that it actually is regression to the mean, because I think you saw over the period of time that it was kind of a slow decrease in events. But my key point is, it's not just an ECG screening protocol. It's a screening protocol that happens to include ECGs. The present recommendation from the circulation group, of which I was a participant, assessing the 12-lead ECG as a screening tool, was not to make it mandatory. No argument against those folks that want to do it for screening. There are some problems with that. I mean, I have problems with it because I think what happens is you determine a lot of false positives. The false positive rates, even with the best screening programs, best ECG screening programs to date, is about 6%. And so that means 6 out of 100 folks are going to have some additional testing required. And with the present high deduction, we not only must make sure we do no harm to people, but we also must make sure that we do no financial harm in that process as well. Here's the 14 points that I'll let you peruse that as you see fit. So back to the guidelines. This is the section 3 on hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, which I'll have a lot more to say about this afternoon, cardiomyopathies and myocarditis. And the key points are that having the gene for hypertrophic cardiomyopathy with no left ventricular hypertrophy allows you to play, something we'll talk about again this afternoon. But just being gene positive is not a restriction. Probable, definite hypertrophic cardiomyopathy, you can't play. No beta blockers, no ICDs, solely to let somebody play. Now, I must admit that I have violated this law occasionally to let folks kind of come to terms with their with their hypertrophic cardiomyopathy and used in ICD. Non-compaction with normal left ventricular ejection fraction, no VT, no unexplained syncope can play. Why do I think this is important? Because we, as I said to the fellows yesterday, are experiencing an epidemic of non-compaction. An epidemic. Now, I don't think there's all that much non-compaction out there. It's just with our present ability to see things in the heart, we're getting a lot more non-compaction cases referred to us. I saw one this afternoon. Symptomatic dilated cardiomyopathy obviously can't play. Myocarditis, 3 to 6 month restriction, and then they can return if they have a normal echo, normal Holter monitor, normal exercise test, and all their markers of myocardial injury, troponins, etc., are reduced. Arrhythmogenic right ventricular cardiomyopathy, you can't play. Why can't you play? Because exercise actually accelerates the appearance of arrhythmogenic right ventricular cardiomyopathy, especially in males, because testosterone accelerates arrhythmogenic right ventricular cardiomyopathy as well. But this afternoon I'll show you some classic studies strongly supporting the idea that exercise training, because exercise tends to stretch the right ventricle, much more vulnerable, the right ventricle, that arrhythmogenic right ventricular cardiomyopathy is accelerated by exercise training. Pericarditis, you can return if normal echo and no marker of inflammation. Quite frankly, I treat pericarditis often the same way I treat myocarditis, because I think that with many cases of pericarditis, there's an epiphenomenon in the myocardium as well. So what about task force 4 in congenital heart disease? The man's too strong, as Dire Straits would say. I can't deal with this. There are so many adult congenital conditions. You have to read it for yourself. It is a very, very hard chapter to go through. So I'll let you follow that on your own. Valvular heart disease, and I participated in this section. It's the same. It's not different. Symptoms, obviously, calculated orifice size or the amount of regurgitant volume, etc. The usual suspects are suggested to be followed in this procedure. Hypertension is fairly straightforward. Treat it. Okay, treat hypertension. Why? If they have resting hypertension, everybody knows that you get considerably higher blood pressures during exercise. Now, unfortunately, there's really no specific drug recommendations, but some of you have seen the controversy in the literature, in New York Times or whatever, just recently, about the use of ARBs in athletes to improve performance. There's this whole literature about the genes of the angiotensin II receptor, of ACE, angiotensin converting enzyme. People with different variants of that gene have either better or less athletic performance. So anything that reduces angiotensin II may be associated with improved athletic performance. Now, I only say this because I have a lot of athletes who don't want to be treated for their hypertension. And I say to them, look, there's all this evidence that people who have a gene that lowers their angiotensin levels are better athletes. They're more likely to climb 7,000-foot mountains. They're more likely to be Australian Olympic rowers, et cetera, et cetera. So I'd like you to try this angiotensin receptor inhibitor or whatever, because it may improve athletic performance. So I use it, unfortunately, to manipulate patients. What about aortic disease, including Marfan syndrome? These were the groups that were addressed: Marfan's Loeys Dietz, familial thoracic aortic aneurysm, bicuspid valve aortopathy. And generally recommended calculating Z-scores, incorporating height, weight, age, and sex. The biggest determinant of aortic size is height, not necessarily BMI. But they recommend calculating these Z-scores, which are, of course, a standard deviation from normal. And so mild enlargement was considered greater than 2, moderate greater than 3.01, severe greater than 4. But remember, for those of us who don't calculate, and the formulas for calculating these Z-scores are in the article. So you have to read the article to get the Z-scores. But for those of us who don't calculate Z-scores all the time, it's very unusual to see an athlete with an aorta greater than 40. Recent publication from the group at Columbia looking at aortic size in NBA, which stands for normal big athlete. It also stands for the National Basketball Association. But in the normal big athlete, very unusual to see an aortic size greater than 42. That was the highest in that National Basketball Association study. But very unusual to see athletes with aortic sizes over 40. We did a meta-analysis of aortic root size in elite athletes with one of the residents at UConn several years ago. Looked at 23 studies, looked at the size of the aortic valve annulus of the sinuses of Valsalva in a lot of athletes in these echo studies. But the point was, it was they were slightly bigger in the athletes, 3.2 millimeters bigger at the sinuses of Valsalva and 1.6 bigger at the aortic valve annulus. Very unusual to have marked elevation. Generally represented some pathological problem. So if somebody has a big aorta in an athlete, really they need additional evaluation. Coronary artery disease was the section that I chaired and wrote. A couple things. We dealt with coronary artery disease, atherosclerotic spasm, dissection, bridging, vasculitis, and also transplant vasculopathy. And divided the athletes with atherosclerotic disease into those that were clinically manifest or concealed. In concealed, we were basically referring to those who had coronary artery disease diagnosed some other way, either by coronary artery calcification score or by some study they got in some way, a coronary MR or a coronary CT. So the risk was clearly increased with those who have manifest disease, with the extent of the disease, with their left ventricular ejection fraction, ischemia, and electrical instability. And one of the things that I think was different about these guidelines and others is that we recommended that you treat people extremely aggressively for their lipids over 2 years before letting them be extremely competitive again. So we all know about this. We all know about the fact that these plaques that are lipid enriched are not only lipid enriched, but they're also macrophage enriched, and they're also matrix metal proteinase enriched, so that the covering cap is much more vulnerable to rupture. Generally thought that in asymptomatic individuals, exercise-related sudden death and exercise-related acute MI were due to plaque rupture or erosion. But then there was this paper that the folks from Mass General and myself worked on, looking at cardiac arrests over 10 years. And again, as I pointed out earlier, a big surprise to us is rather than finding a lot of coronary ruptures, there were a fair number of people who had myocardial ischemia. There were 5 cases, very small, where plaque rupture was not found on either angiogram or autopsy in patients with coronary artery disease. Again, raising that possibility that some of these exercise-related deaths are not related to plaque rupture, the way we think of, an acute MI or acute sudden death in people that are previously asymptomatic, but they may be due to exercise-induced ischemia. And I showed you this slide before, the fact that there are a fair number of these folks. The group down below here is the group dying during exercise. This is middle-aged people just dying. This is dying during exercise. But you can see non-acute coronary disease in this sort of pink color is very prominent. I do want to point out that acute coronary thrombosis does occur. These are 3 men who came into Tufts to Mark's Place right after the 2011 Boston Marathon, and each one of them had an acute coronary thrombosis. So it may be that there are different pathological substrates which cause sudden cardiac death in NMIs with exercise. Although exercise and sudden cardiac death in MI in asymptomatic subjects is generally thought to be acute thrombosis, and sudden cardiac death in known coronary artery disease is generally scar-related, ventricular fibrillation-related. More asymptomatic subjects than previously thought may have exercise-induced ischemia. I think it's important because, again, I think we need to rethink some of the ideas on exercise testing before athletic participation. So we thought it was reasonable to perform an exercise test on their medical regimen to measure LV function, to allow athletes to participate in the decision, to pursue aggressive risk reduction, and allow participation if left ventricular ejection fractions were okay, no ischemia, no electrical stability. Thought to restrict competition for at least 3 months after an acute coronary syndrome, PTCA or CABG. My own opinion is that this ought to be much longer, And let me just show you in a minute why. So here's a study from the people in Seattle looking at carotids. So these are folks that are put on lipid-lowering therapy, and their carotids are measured looking at the amount of cholesterol is in their plaque. So this is somebody at baseline, and here's the amount of cholesterol in their plaque at 3 years. And here's somebody else, and I think you can see over time the regression of this atherosclerosis, this eccentric atherosclerosis. And this is shown here, that you get a big reduction with aggressive lipid reduction in year 1. You get an additional reduction in year 2, but then it tends to flatten out. So the idea was, treat people very aggressively for 2 years. Try to restrict them from the most intense competition for those 2 years. That will help you get cholesterol out of the plaque, macrophages out of the plaque, matrix metal proteinase out of the plaque, and maybe help to stabilize the plaque so that they'll be safer for return to competition. One of the residents as well with me looked at a review of the course of atherosclerotic plaque regression. There were a lot of articles. 31 showed there are 31, 11 carotid, 16 coronary, some aortic regression studies. On average, you got regression in about 19.7 months, and you got it with about a 40% LDL reduction. That characterized those studies that showed regression. Regression increased with a percent LDL reduction in the intensity of statin treatment. I always tell my patients that I think of atherosclerosis as a fire in the endothelium. And if you're a smoke jumper, what do you want to do? Well, you want to jump into some place where there's not a lot of fuel. Because if there ain't a lot of fuel, you'll have a better chance fighting the fire. So the whole thing with managing athletes with atherosclerosis is to get the atherosclerosis down, to get the LDL down, to get rid of the fuel. I think I told you that. So arrhythmias and conduction defects. Patients with pacemakers were generally cleared for competition, but again, at very low levels most times. And athletes with ICDs were restricted to the lowest levels of sport. Those with channelopathies, these were the channelopathies dealt with. And the take-home message basically is, get them to a specialist. That was the general recommendation, that you can try to play around with these as a general cardiologist, but your smartest approach is to get them to somebody who's an expert in it. Mark talked about performance-enhancing drugs. Mark talked a little bit about cardiopulmonary resuscitation. But facilities should have an emergency plan. One of the best things you can do as a cardiologist advising a high school or whatever is to have them have a plan, practice it. Know which door the EMS should go to. Work with your local fire departments and emergency personnel so that you have a good plan. Coaches should be trained to recognize and respond. I've always pushed for coaches to be required to know CPR and now to be required to take a course in AEDs and stuff like that. It's not done most places, but it would really help. And as Mark pointed out, AEDs in 5 minutes, post-direct care, etc. Commotio cordis, that's been dealt with. I'm going to skip that. Sickle cell trait, preventive strategies to avoid this rhabdomyolysis. Beware of the risk. They're much more vulnerable to exercise in the heat, to dehydration, and to altitude. Legal aspects, Mark's going to talk about this afternoon. So with respect to legal aspects, there are 3 things you need to do. You need to document, you need to document, and you need to document. So if you have a discussion with an athlete and you decide to let that athlete play, and that's a mixed decision, you didn't restrict one way or the other, document what your advice is and why it was changed. Now, did you have the sound for this? Can you put the sound in for me? Because I don't think we set up the sound. So, I want to point, should I just go ahead and do it, or? Okay, do you think it will work? So I'm going to have to turn the sound up all the way. So this is my favorite Saturday Night Live clip. And here we go. Can't hear that, can you? You know what? We'll probably have to skip this. You can't hear it, can you? All right. So he says, by the way, my name is Bruce Dickinson, the Bruce Dickinson. I put my pants on one leg at a time. But once my pants are on, I make gold records. So I'm going to skip that. But the point is this. The point is that the people that make these guidelines are not that different from you, right? So make sure that these guidelines are used only as that, guidelines, because you're the clinician on the front line. So guidelines are very conservative, and you have to use them with some discretion. Thank you very much.